Hello, my name is Dr. Mario Romero, and I am the Clinical Director for Romero Dental Seminars. In this webinar, I'm going to share with you important clinical information related to bulk fill restorative materials. I hope you enjoy. Today, we are going to talk about the bulk fill revolution. In 2007, the American Dental Association published the results of a survey conducted between 2005 and 2006 of dental services rendered in the United States, and found that the number of composite restorations surpassed the number of amalgam restorations placed on posterior teeth. Over 76 million resin composite restorations were estimated to have been placed in 1 year on posterior teeth. For years, we have been layering posterior composites with a high degree of success. So the question is, how can bulk fills help? One of the known downsides to layering composite is controlling the thickness of each layer. Ideally, each layer should not exceed the 2 mm thickness mark. This is important since the degree of conversion of the monomer to a polymer during light polymerization is directly affected by this. Different studies have shown that it is difficult for us to control direct composite layer thickness. In this study, 60 dental students and 15 dental school faculty were chosen and divided into 4 groups. They were given a 3D printed tooth model with a Class 1 type of preparation. They were told to restore the tooth using 3 2 mm increments of composite. They used light shade and dark shade composites so they could be differentiated during evaluation of the specimens. The participants did not know the dimensions of the preparation, nor did they have any measuring instruments. Once the restorations were completed, the models were sectioned and observed under a microscope to measure the increments. Here, you can see a diagram of the tooth model used. The preparation had 6 mm in depth, and there was a 2 mm ledge on the occlusal to serve as a stop for the tip of the curing light. Here are some of the section specimens, where the range for the layer thickness is evident. On the left side of the screen, you can see a specimen with a small deviation from ideal. But look at the specimens on the right side. It is clear that the bottom layer thickness was overall affected the most. In this chart, we can look at the results of the study. I would like to comment on the faculty group, since this group has more clinical experience. One critical aspect that needs to be evaluated is the layer thickness of the first increment, since the bottom surface of that layer is furthest away from the curing light. For the faculty group, the bottom layer exceeded the 2 mm thickness target 60% of the times, followed by the middle layer 47% of the times, and finally the top layer 27% of the times. Wouldn't it be beneficial to use a bulk fill composite that requires no layering? Would it help clinically reducing the possibility of lack of degree of conversion? So let's get to know bulk fills a little more. How are they classified? Bulk fills can be classified by their viscosity or by their polymerization activation mode. In regards to their viscosity, they can be low, medium, or high. It is important to mention that companies that fabricate low viscosity bulk fills normally recommend a final capping layer of regular microhybrid composite since the amount of filler has been reduced to increase flowability. On the other hand, the medium or high viscosity do not require this step. In regards to its activation mode, they can be light cured or dual cured. One of the benefits of dual cured bulk fills is that the depth of the restoration is not a concern as it is for the light cure bulk fills, since the evidence has shown that the latter performs best at depths no greater than 4 millimeters. Fill-up from Coltene is an example of a medium viscosity, dual cure bulk fill composite. Other in vitro studies have looked at bubble formation and marginal adaptation of bulk fill composites in Class II preparations. In this unpublished in vitro study, recently completed, where we compared two commercially available bulk fill composites, one high viscosity with fill-up medium viscosity from Coltene, we found that bubble formation within the high viscosity group seen on this slide was significantly higher than compared to the medium viscosity group. A uniform bubble-free restoration could be seen in some of the specimens in this slide. Now, let's look specifically into what considerations are needed in regards to bonding dual cure bulk fills like fill-up. One of the things we need to consider is the pH of the dental adhesive. The number to keep in mind is a pH of 3. When a universal dental adhesive has a pH lower than 3, which means that it is more acidic, it could affect negatively the dual curing properties of the bulk fill. 1-Code-7 Universal from Coltene has a pH lower than 3. So if used in combination with fill-up, you need to combine it with the 1-Code activator. This activator will increase the pH and thus allow the dual curing properties of fill-up to work properly. To help you understand the clinical steps when combining these two products, step number 1 would be to decide your etching strategy: total etch, selective etch, or self-etch. Step number 2 is to apply 1 to 2 coats of 1-Code-7 Universal on the preparation. Step 3 is to mix 1 drop of each 1-Code-7 and 1-Code activator and then apply 1 to 2 coats on the prepared tooth. Eliminate any excess and light cure. Now, you are ready to restore using fill-up bulk fill dual cure composite. Another option would be to use the chemically cured adhesive system also made by Coltene, Parabond. The only thing you need to consider is that Parabond requires a total etch technique. This is a great adhesive system with multiple clinical applications. Now, I am going to walk you through a step-by-step direct posterior composite clinical case using 1-Code-7 Universal and Brilliant Everglow. I want you to pay close attention to the number of steps required so that we can then compare them to a bulk fill like fill-up. In cases where enamel is present, I always recommend total etch or selective etch technique. I choose the latter option when deep dentin is present. After rinsing the acid, I apply 1 to 2 coats of the universal adhesive to the dentin and the enamel with a rubbing motion, followed by elimination of the solvent and the excess with a gentle stream of air from the air-water syringe. For the restorative technique, I start with a horizontal layer as seen on the photo on the left, followed by 2 oblique layers to restore the buccal and the lingual cusp inclines. For more natural looking restorations, I like adding the gold stain effect that is part of the Miris 2 restorative kit from Coltene. Once occlusion is adjusted with multi-fluted carbide burrs, polishing is achieved using the ShapeGuard 2-step system. Now, we are going to restore a class 2 preparation using Philip dual curing bulk fill universal shade. After preparation is completed, we place a retraction cord around the affected tooth to aid in rubber dam inversion and ideal isolation of the tooth. One of the things I like the most about Philip is its delivery system. This auto mix tip is long and thin enough to reach the bottom of any deep class 2 box, dispensing the restorative material in an easy and predictable manner. Once hybridization is completed, we simply fill up and cure. Here is a side-by-side photo of the before and after. Look at the chameleon effect properties of the universal shade as well as the smooth surface we were able to achieve after occlusal adjustment using shape guard system. Can we make restoring posterior teeth easier? For this large class 2, we are going to use Philip bulk fill combined with Parabond's self-cured dental adhesive system. After removal of the fractured amalgam and caries dentin, a 15-second total edge technique is completed. We mix 1 drop of each Parabond A and B and apply 2 to 3 coats to the dentin and enamel with rubbing motion. We eliminate the excess and the solvent with a gentle stream of air for 5 to 10 seconds. We fill up in one increment, followed by finishing and polishing. As you can see, there are less steps and results are as good as with layering technique. An added benefit to bulk fill composites like Philip is that they can be used as core buildup materials. Not only is this a clinical benefit, but an inventory benefit as well, since it reduces the number of products a practice needs to purchase and store for clinical care. My recommendation for this clinical application is to combine Philip with Parabond self-cured adhesive. After root canal has been completed, we place a Toffelmeyer band and wedges, followed by total edge and adhesive application, as per instructions previously discussed. On the left side of the screen, you can see the completed core buildup, while on the right is the completed onlay preparation ready to be scanned. Once the restoration is milled, stained, and glazed, we are ready to deliver using Duosem dual cured resin cement from Coltene. In this other case, our patient presented with deep caries lesions on 8 and 9. In both cases, it involved the pulp, so we planned for root canal treatments and 2 full coverage ceramic restorations. While the patient is being treated by the endodontist, we wax the case up for fabrication of the temporary restorations. Once the root canal treatments were completed, we proceeded with our core buildups using Parabond and Philip bulk fill. In this photo, you can see the final crown preparations with the red arrows showing the transition between Philip bulk fill and the dentin. The day of delivery using Solosem self-adhesive resin cement from Coltene. This photo was taken immediately after cementation. And this photo 30 days after. Note the natural appearance of the restorations and the healthy tissue surrounding them. One more from a side view to evaluate the natural texture that the lab was able to reproduce on these ceramic restorations. In summary, Bulk fill restorative materials like Philip have gained popularity among clinicians for reasons like ease of use in a variety of clinical applications, like large Class 1 and Class 2 preparations, as well as a core buildup material for partial and full coverage ceramic restorations. I hope you found this information clinically relevant and useful for your daily practice. Don't forget to visit our webpage, romerodentalseminars.com for more clinical tips. Thank you for watching.